So today I'd like to spend a little time talking about fertility preservation resources and oncofertility education resources. So just as a quick highlight about the fertility preservation space or oncofertility space, an average of about 70,000 women and men are diagnosed with cancer during their reproductive years, which is technically considered between 15 to 39. With reproductive medicine advancing so much, there are women and men who are having children at older ages as well, but the statistic has not quite caught up to that research. Of that 70,000, about 40 to 80% of women and 30 to 75% of men are at risk of fertility compromise as a result of the type of cancer that they have and or the treatments that they will receive for that cancer. In a survey that we conducted in 2017, about 79% reported that they did discuss fertility issues with their provider. I do want to note that this population was a bit biased because a large percent of them had already accessed LIVESTRONG Fertility services, so it would make sense that they had that conversation. There were people who did not have that conversation, and the most prevalent reasons for not having that conversation was because they didn't know or they had children already and their provider made an assumption that they didn't want more children, or because they didn't have health insurance and they weren't as educated as some of their counterparts. We have published the results of this study, and we continue to advocate for more and more people, especially providers, to have this conversation with their patients. Of the 79% who did have these conversations, 24% reported that they brought this conversation or this topic up themselves. So I think the key takeaway, at least for me here, is that it's really important for us to teach patients how to self-advocate. And that's why the education resources that we're going to talk about today and the preservation resources are so important, is so that you have the information and you can be armed with advocating for your own interests. This is a really promising time for both oncology and reproductive medicine. So with 80% of survivors expected to live at least 5 years or more, survivorship is or post-treatment survivorship is incredibly important. And among young adults, fertility preservation, or the ability to have children after cancer, is one of the things that they've reported is extremely important to them. Because for a lot of people, regardless of whether they know whether they want children or not, they want that option, and they want that option to be theirs, that decision to be theirs, not cancer's and not their providers. So it's incredibly important to them that and to this population, that we educate everybody about your ability to preserve and talk about some affordable resources, because it can get a bit pricey. Feel free to stop me at any point if you have questions. So a little bit about some education resources. There is a lot of information out there, and these are great in getting the conversation started with your provider. So while it's really great to have all of these resources and learn about options, it's also really important to take this information back to your healthcare provider or your team and talk to them about what may be right for you. So like I said, 40 to 80% of women and 30 to 75% of men are at risk. So it may not be you, but you definitely want to have that conversation just to know what your risk level is. So some of the places, the very trusted resources that have good information on oncofertility education or cancer-related fertility risks is the American Society for Reproductive Medicine. They have these one-page fact sheets on their website that are really great, and they talk about the risks as well as preservation options, and everything is just really easy to find on their website, and even if you just Google ASRM fact sheets, it'll come up. The Oncofertility Consortium also has some really great resources on their website, and they also have a helpline that you can call to find a fertility preservation program near you, which is really important. LiveStrong Fertility, that's the program, one of the programs that I manage, and we'll talk a little bit more about that. But the picture on the right there is a picture of our website, and we've got a lot of information about the risks of cancer on fertility and different types of cancers. We've got information on preservation options, and we've also got information on what does parenthood look like after cancer if you haven't preserved already, including adoption and surrogacy. SaveMyFertility.org also has some great information on their website about the risks and preservation options as well. Same for Fertile Action. Cancer.net is a much wider resource. This is my go-to resource for anything related to cancer. And they also have some great resources on fertility preservation. Cancer.net is managed by the American Society for Clinical Oncology, which is why I trust it a lot, is because all of the information is vetted by clinical oncologists. So it's very trustworthy. Have you all accessed information about fertility risks? Yeah. Where did you find some of that information?
LiveStrong Fertility.
Oh, awesome. Yeah.
I went through LiveStrong Fertility in 2015 and the 2 rounds of fertility.
Oh, great. Thank you for sharing that. Yeah. Anybody else? Yeah.
Also LiveStrong.
Okay. Thank you. Great. How many of you are interested in learning more? I mean, you're here, so you all are interested, but in pursuing it, or Sam? Awesome. Great. So fertility preservation resources. Once you educate yourself and you have that conversation with your provider that this is something that's appropriate for you at whatever stage you are at in your cancer journey, these organizations provide either financial assistance or more information about fertility preservation. So LiveStrong Fertility, I'll talk more in depth about it on the next slide, but as a high-level overview, we provide discounted access to fertility preservation and free fertility stimulation medications for pre- and post-treatment young men and women who've been diagnosed, as well as women whose male partners have been diagnosed with cancer. Fertile Action, and we're a national program. Fertile Action is also a national program, and they provide financial assistance to people who've been diagnosed with cancer, and it's only women, and it's pre-treatment U.S. citizens only. They are also a national program. Walgreens Heartbeat is an extensive program that is also national, also only for women, and they provide only the free stimulation medications, and they're partnered with Ferring Pharmaceuticals for that. Fertility by Design is a program based out of California, so if anybody is in California, they provide discounted fertility preservation at their clinics, and they also provide the free stimulation medications in partnership with Merck. Chick Mission is a relatively new organization that is based in New York. It was started by a cancer survivor, a 4-time cancer survivor, and she's an AYA, and she kind of just had enough about this lack of appropriate resources in her state particularly. So Chick Mission provides financial assistance for fertility preservation, and often they will try to cover the full cost of the process for you. Partnership for Families is a regional organization. It's unclear to me exactly what states they're in, so I don't have a lot of information about them, kind of similar with Team Maggie, but both of them provide financial assistance for fertility preservation, and both of them are also women only. Actually, I think Partnership for Families is women and couples, so they don't do single men, and then Team Maggie is women only. Any questions?
Which state is Chick Mission?
New York. Yeah. So LiveStrong Fertility. This is don't tell anybody, one of my favorite programs that the foundation provides. We acquired this program. Actually, it used to be called Fertile Hope, and we acquired it in 2009. Since the program started back in 2004, which includes the period that it was Fertile Hope, we've served over 11,000 cancer survivors, and we've helped them save over $54 million in fertility preservation costs as well as the stimulation medication costs. So how do we do this? LiveStrong doesn't actually provide any free or financial assistance. What we do is we're kind of a mediary, a facilitator. So we have agreements with over 700 fertility clinics and sperm banks across the country, and we mandate that they provide a minimum of 25% off of fertility preservation resources. And the current types of preservation that are included are egg and embryo freezing, sperm banking, and fresh and frozen IVF. We started including frozen IVF because a lot of our cancer survivors were requesting that because you need to do if they would like to do genetic testing, it has to be frozen. And so that's why we started including that. Yes?
How many days for embryos that can they be tested for genetics? Is it 5 days, or I have embryos 3-day-old, like?
I'm going to punt that question to Dr. Abia.
It's usually a 5-day blastocyst, but
So they're younger, they're gonna be tested.
they can do 3-day, I think, but 5 days typically.
Is there risk for the embryo? Like, can they die from doing the testing?
So typically the testing is of the placental tissue, or the cells that will become the placental tissue. But as you can imagine, the more robust, the number of days you allow growth, the more of those cells that you're going to have for the placental testing, as opposed to the inner mass, which is going to be the fetus. So it needs to be, but before they transplant, they're going to allow the blastocyst to grow a little bit further. So if you have early blastocysts, they can still, during the maturation phase, test it at that point.
And there's no risk of losing them?
No, the risk is very low. Very low.
Any other questions? Great. So in addition to this ever-growing network of clinic partners, we also are partnered with EMD Serono, which is a pharmaceutical company that has been very generous in providing free stimulation medication to women who've been diagnosed, as well as women whose male partners have been diagnosed. What's really exciting is the broad eligibility criteria that LiveStrong Fertility has. So we're the only program in the country that I'm aware of that currently accepts pre and post treatment, and that also accepts women, both sexes, all genders, and women whose male partners have been diagnosed. There isn't a lot of resources out there for them. And we also provide, the depth of our services, we also connect people to other cancer support resources if they come through LiveStrong Fertility, so that we're making sure that they have a whole person experience with us. So it's truly a wonderful program. We also are very quick and easy in terms of how you get to access our services. So someone completes an online application, your reproductive endocrinologist, if you're female, does need to sign off on this because they need to prescribe your medications. And it's very easy because you just send them an email through the system, they complete their paperwork, and then as soon as we receive a completed application, we process within 24 business hours, and then because we know that this is usually very time sensitive, and then the medications are overnighted to you so that you can start them as soon as possible. We do have a lot of clinics that go above and beyond and offer 50% off of the fertility preservation service, which is really remarkable and pretty incredible. We do also have some eligibility criteria in place, so we're also the only program that doesn't require you to be a U.S. citizen in order to access the program. You do need to be legally present, and if you're female especially, because our pharmaceutical provider unfortunately can't donate medications to someone who is not legally present in the U.S. But this was something that I was personally very excited about, because it doesn't mean that you have to be a permanent resident or a U.S. citizen. If you're a student and you've been diagnosed here, or if you're visiting and you've been diagnosed here, or if you're on a work visa and you've been diagnosed here, you still have access to these financial support resources that you shouldn't be discriminated against because of where you're from, because cancer doesn't discriminate. So I also wanted to talk about emotional support resources, because this is something that I think we all kind of skip over, especially when you've just been diagnosed with cancer or at any point in your journey. You're so focused sometimes on the cancer itself, on beating the cancer, and then doing all of these things to make sure that you have a really great life after cancer, that we forget to take care of ourselves. Or we focus on the physical so much that we don't focus on the mental, emotional, spiritual aspects of our self. So these are some really wonderful organizations that provide emotional support or emotional support resources. Cancer Care is a national organization that provides free phone-based counseling, and they provide, I think, up to 6 or 8 sessions at no cost, and then after that they may connect you with a long-term counselor. They also have a lot of online support groups, and they provide in-person services in New York, New Jersey, and Connecticut. Immerman Angels is a really great program that is a great organization that provides peer-to-peer matching services. So if you're interested in connecting with another cancer survivor one-on-one who's been through a similar cancer diagnosis as you have, is a similar age range as you are, or a caregiver, then this is a great organization to connect with. If you're local to Austin, Regarding Cancer is another organization that's based here and that only does Austin, but they're just truly wonderful, and they have a really large volunteer base of cancer survivors that are willing to connect. Yes?
What about, do these resources include also like post-fertility preservation support?
So a lot of them aren't. No, they're not specific to fertility preservation. I think Cancer Care you would get pretty close, and Immerman Angels you could request a peer mentor who has been through a similar experience, but Cancer Support Community and the rest, no.
Okay.
Yeah. And that is an area that Livestrong actually did a lot of work in, and when we provided counseling ourselves, we did have a subspecialty. We no longer offer that program. But we recognize that as a need, and what we'd like to see is more cancer centers offer that through their social workers themselves. So that's what we're currently trying to encourage. So Cancer Support Community is another great organization that provides emotional support, and they have a chat service, which I think is really great for when you're just feeling really low and you want to chat with someone really quickly. They're a great resource. Cancer.net, I mentioned that they're kind of my go-to resource, so they have a lot of information about emotional support, managing your emotions yourself, and really great techniques and tips. Livestrong also has a lot of great resources. I strongly recommend journaling and meditation. Meditation is really hard, and you can feel like a failure, but you're not. You're progressing every time you sit down to do it, even though your mind wanders a lot. For Austin folks, the Flatwater Foundation is a wonderful resource. They are expanding to other parts of Texas. They provide free counseling. So it's professional counseling. They connect you with a counselor, and they cover the costs of your counseling sessions. And it's lifelong. So this is truly a wonderful resource. And then there are lots of in-person and online support groups. Check with your clinic. They will usually have resources in terms of in-person support groups. And online, Facebook is actually a really great place to look for support groups. There are lots of homegrown groups on the social media platform, which I've heard from a lot of survivors is really helpful for them because they get direct connection into a large group of cancer survivors that have been through exactly what they have been through, or pretty close to what they've been through. And then I do want to point out that the picture on the right, I really took it just for the first part, which is unity is strength. You're not alone, and it's important to remember that you're not alone. Cancer can be extremely isolating, and going through a potential infertility diagnosis can be even more isolating. And there are just lots of issues associated with fertility and being a woman and all of that, and then your body changing. And so it's really important to recognize that you aren't alone. There are so many people that are going through this. Option B, that was started by Sheryl Sandberg, is also and sometimes a good resource. They have a fertility support group on their site. It's not cancer specific, but they would be, if you're open to not something that wasn't necessarily cancer specific and just wanting to connect with others who have been through or who are going through fertility struggles, that's a pretty good place to connect. Then I wanted to share this because this slide always, and these pictures always give me hope. And hope is something that can't be taken away from you. As I'll share a story with you about a survivor who has accessed our stories. He's a brain cancer survivor. His name is Aram, and he's a very vocal cancer advocate. And he now has, his daughter is, I think, 9 at this point, and he was diagnosed when she was 3. And he just lives with cancer as a chronic illness. And about a year ago, he went in for his last scan, and after the scan, he was in the car with his daughter. They were driving, and she said something along the lines of, I hope you're cured. And his response was, well, that's unlikely. I think I'm never going to be cured. I'm just going to live with this for the rest of my life. All I can hope for is that it hasn't grown. And his daughter responded that, you can't take away my hope. That's mine. So I love to share that story because nobody can take your hope away. That is something that lives within you, and that is your attitude. And on a previous slide, we say attitude is everything, and it really does make such a difference. It doesn't mean that you don't allow yourself to feel your feelings, no matter what they are, but always remember that there is hope. So Jordan on the far left, those are his and his wife, their twins right below them. They used LiveStrong Fertility, and they had those twins while he was in treatment, which was just so beautiful that they shared that with us. And we've got some pictures of them wearing LiveStrong onesies, but I thought that was just the sweetest picture. In the middle top, we've got Sarah and her daughter. Sarah is a 2-time breast cancer survivor and preserved the first time. The second time, they were just ready to wanting to have kids, and they were unable to because of her second diagnosis. So her sister-in-law was their surrogate. And LiveStrong Fertility, I forgot to mention, we help people with surrogacy as well. So we will cover the costs of the fertility preservation, or the discounted fertility preservation, and the free medications for surrogates as well, and for egg donors. The second, or the middle bottom, is a couple who was just recently married, and a few weeks after they got married, she was diagnosed with cancer. And there's a wonderful blog that she's written on our website about her relationship with fertility and what that was like after being so newly married. And then the top right are Connor and Reese. They are also twins that were born as a result of LiveStrong Fertility, and their dad is a childhood leukemia survivor. And on the bottom right is Wendy and her family, her daughter was also born as a result of LiveStrong Fertility, or the support that she received through the program. And she's a very vocal fertility advocate as well as a cancer advocate. And she lobbies a lot for cancer research and financial support. So every time you face doubt, just remember there is hope. And here's all of the people that experienced it. Any questions? Yes.
You talked about emotional resources. How about resources for just post-preservation issues in general? You mentioned maybe option B, if I were trying to look into other issues or other things, the next step, like surrogacy or
yeah.
having problems with my current clinic.
Yeah, that's a wonderful.
Mind repeating the
Oh, sure, the question. The question was, if I heard it correctly, was are there any resources for post-preservation? So for surrogacy and advocacy. And are you asking specifically for emotional support resources related to that?
Well, you talked a bit about emotional, but just like the issues in general, like I'm trying to find a new clinic or, yeah, something like that.
Yeah. So I think if you were trying to find a new clinic for surrogacy, it would be a pretty similar process, at least through LiveStrong Fertility. You would just find a clinic using our tool. If you're interested in using a clinic that's already partnered with us, you can choose your own clinic that isn't partnered with us, and we will reach out to them to see if they're interested in joining our network. But that's really your call. But if you want some guidance, you can always contact LiveStrong Fertility. And our website is livestrong.org/fertility. So that's a pretty great tool. And then for adoption, I don't have as many resources on that, but if you give me your contact information, I'm happy to look into that and then follow up with you. Yeah.
And as part of the concern that the fertility clinic you're dealing with is maybe not meeting your needs medically?
I'm not happy with how the preservation process went.
Okay.
And the current care and communication.
Okay.
And moving forward with the next step in surrogacy and even just storing the embryos there, I'm just not comfortable with that.
And where do you live?
LA.
LA.
Yeah.
All right. Okay. I can help think through that too. I mean, there's
Great.
fabulous people in Colorado. I know somebody in LA, but I don't know, maybe that's who you're using. We'll have to figure that out.
Okay.
We'll see. Okay.
Yeah. You had a question.
Yes, again. For hormone-positive cancer, is there like a percentage if you wait 2 years versus 5 years of risk of recurrence? My oncologist said minimum 2 years, 5 years. And
Sure, I'm going to talk a little bit about that, but we recommend that you wait 2 years because of risk of recurrence if you have early stage disease up to 3A. If you have regional spread, if you have spread to the lymph nodes, then we recommend 3 years. But if you are early stage, then 2 years would be appropriate. Some patients we kind of negotiate about because some patients really want to start sooner. You need to wait at least 6 months for improved mortality and also for efficacy because it takes about 6 months from the last chemotherapy exposure for those eggs to recover and to lose the risk of DNA damage. The studies, large population studies, show that after 6 months that we think it's safe in terms of mortality, but recurrence can occur within 2 years, and so we really want patients to wait those 2 years if possible.
So if you have
2 years from last treatment.
If you have recurrence within 2 years, does that number increase in waiting before trying to conceive? Or?
Say that again.
So let's say you wait if there's a recurrence diagnosis
Within 2 years.
within 2 years. Do you have to wait another 2 years?
Yes, you need to wait until you complete whatever chemotherapy you're going to complete before you move forward. It's sometimes conflicting between diagnosis. Is it 2 years from diagnosis or 2 years from end of treatment? And it should be end of treatment, which usually spans about 6 months.
Is it like a year of Herceptin? Is it like the full year of Herceptin too, or like the majority of like your?
The chemo, the Herceptin doesn't count. You just need to wait 4 months from when you finish Herceptin to conceive because it is a teratogen. It can cause birth defects, so you don't want to conceive on Herceptin. So let's say you completed your chemotherapy a year ago and then started Herceptin a year ago, and let's say today was 1 year from Herceptin, you're free to conceive at least 4 months after you finish your Herceptin.
Switch pairs with Herceptin after that.
Yeah, it's about the same.
I think that's a perfect segue into Dr. Afia's presentation. Okay,
so I'm just going to jump right in. So I do have a financial disclosure. I have an LLC, Preserving Fertility LLC, and that's the URL. And it's basically a public speaking company to educate women about their reproductive health as relates to cancer, and not just breast cancer, but any cancer diagnoses. But other than that, I have no conflicts. My hope is that at the end of this discussion that you will feel more able to advocate for your reproductive quality of life in survivorship. So over the last several decades, the incidence of cancer has remained relatively stable at about 1.7 million new cases in 2018. So for many years that was steadily rising, and now we think it's a bit stable. Of those, about 70,000 persons will be in what we call the AYA group, the adolescent and young adult population, or of reproductive age. The 5-year survival rate for all cancers in that group are about 70%, which is a little bit lower than pediatric cancers, and that's because the young adult population tends to have some other things going on that make access to care an issue, financial strains, work, employment. So the overall survival is a little bit lower in AYA populations. But over the last several decades, you can see that the cancer incidence for reproductive age women has increased steadily. The 5-year survival rate in breast cancer is 90%, though. So we do really well in terms of survival in breast cancer, and all of you are a testament to that. And as you know, the earlier the diagnosis, then the greater the survival. This slide just shows you kind of the distribution of cancer incidence. So the majority of breast cancer is diagnosed in women 55 through 65, and then followed by 45 to 54. But about 10% of women of reproductive age will have breast cancer. So 10% of all cancers occur in women of reproductive age from ages 44 down to age 20. We don't see breast cancer under age 20, thankfully. So due to advancements in treatments and early detection, survivorship has just escalated, and we think that by 2030 there are going to be over 20 million survivors of cancer. So that means that 2/3 of these patients are going to experience late effects. So the more survivors we have, the more individuals are going to experience the effects of cancer treatments. And so focus has shifted to include quality of life. Before, we were very concerned, we're still always concerned about survival, but now we realize that equally important to survival is your quality of life in survivorship. And fertility is one of the important quality of life indicators in survivorship. We know that 70% of cancer survivors want to have children before, even if they have had a child prior to their diagnosis, and so that we know that it's a very important aspect of your survivorship. Unfortunately, and this is a scientific slide, but I know you guys can handle it, so we're going to walk through it. So 1.0 is neutral. So you'll see on the right of this is the percentage. Do you see the mouse at all? I don't see the mouse. Do you? Okay. On the right of this is a percentage of patients who are going to have a higher pregnancy rate than the general population. And then to the left of this shows you the likelihood of pregnancy being lower than the general population. So as you can see, for all cancers except maybe thyroid cancer, the likelihood of pregnancy is lower. And when you go all the way down to breast cancer, that likelihood of pregnancy is the lowest. And a lot of that has to do with perception and myths, not necessarily the treatment. There is a perception that if I have breast cancer, then I can't have children or I shouldn't have children, and that is simply not true. It depends on the stage, and even, as I stated, in patients with later stage disease, after a period of time of surveillance, we do think that patients can conceive. And studies have actually shown that women who do have a pregnancy, with breast cancer who do have a pregnancy, actually have a longer survival than those who don't. And we think it's something like a maternal effect. There's two things that are going on there. One, you're more likely to conceive if you have a better prognosis, right? So that's one reason. The other cause is we think that the hormones of pregnancy actually destroy some early breast cancer cells, and so that it can be protective. So depending on what your stage is, pregnancy in survivorship is feasible. And so that's an important message. So what happens is women who have breast cancer, they either abort
or they don't conceive because they think that that's the right thing to do, and it isn't. And so we want to work on educating our patients about pregnancy after breast cancer. The treatments that we use currently for cancers are multimodal, so they include surgeries, removal of the actual tumor. Chemotherapy is multimodal, so you will have experienced that you receive 3 or 4 different cancer treatments or chemotherapeutic agents during your treatment. That makes it a little bit challenging for us to know which of those treatments is most harmful to fertility, and that's why it's somewhat difficult for us to give you a really good risk assessment at the time of diagnosis, but we have gotten better at that over the last several decades. Radiation therapy can affect fertility, and then we have these newer agents called biologics, which we are pursuing to try to minimize the effects of cancer treatments on fertility. Again, this is a scientific appearance slide, but you can do it. So what this is showing is that at birth or prior to birth, we have all of the eggs we're going to have. And then over time, through death of those eggs and through ovulation, we lose our fertility. So at age 25, our fertility starts to drop. At age 35, it significantly starts to drop. And then by the time we have 1,000 eggs left, we're in the menopause. And so what I want to explain to you about, I want to use this slide to explain to you what cancer treatments do to fertility. So you can see here, down at the bottom, I cannot see the mouse. I'm going to step over here. Okay, so you can see here down at the bottom, this is where we're going to have the greatest number of eggs that we're born with. And then over time, we lose 90% of our eggs through cell death, and then we lose 10% through ovulation. And so every month, we recruit 1,000 follicles. The majority of them die off. All cancer treatments will affect these growing cells here. So what that means is that those growing cells produce estrogen. So during your cancer treatment, you stop having periods because those growing cells are destroyed, and so then you don't have the ability to ovulate during treatment. When you finish treatment, because we have all of these eggs that we were born with, they continue to grow, we continue to ovulate, and our fertility returns. The problem comes when we receive treatments that are called alkylators, or if we receive radiation treatment. So some of the alkylators that may be in breast cancer treatment are cyclophosphamide. Some of the taxanes are considered alkylators, so paclitaxel, docetaxel. Those chemotherapeutic agents destroy not just the growing follicles, but also these follicles that are our reserve. But when we finish treatment, we will start to have a resumption of follicles and ovulate. The problem is you go from having this number of follicles to more like this number, right? So that means that although you may start to have periods again, and although you may have some fertility, the reproductive window is shortened. That means that you don't have the luxury necessarily of waiting to finish grad school and travel the world and all the things that you may have thought you wanted to do. The window of opportunity is shorter, and these follicles will get exhausted quicker with an earlier presentation of menopause. And so this is just really important for me that patients understand, because I see patients who haven't had periods for years and have no idea that that means that they can't have babies. Or patients who think, well, I have periods, so I must be okay, and that is not true. And we've educated our oncologists that periods do not equate to fertility, and patients need to have an assessment to make sure that they actually have their fertility after treatment. Okay, so in terms of which treatments or which conditions are more problematic, we typically stratify high risk, medium risk, and low risk of infertility. So you'll see high risk includes patients who get stem cell transplants, patients with Hodgkin's disease who had really strong alkylator treatments that we discussed. Breast cancer falls into this medium range population, similar to patients who receive newer agents for Hodgkin lymphoma or have osteosarcoma. And then low risk are patients who have leukemias and germ cell tumors of the ovary. Now you can see here that medium risk is 30 to 70%. So that's difficult, I think, for a patient to wrap their head around. What does that mean? Am I at 30% chance of infertility? Am I 70% chance of infertility? And then what should I pursue? Should I freeze my eggs if I'm 30% or not? And so this is an area of rapid research to really understand how we can use your age, your baseline fertility, your treatments to give you a better assessment of what your risk is. Because it seems a bit unfair to me to just throw out that broad range and then expect you to be able to make a decision, right? It's very difficult, but we do walk through that. It's important for you to know the younger you are, the lower risk you are of infertility. The older, 35 and older, the more likely you are going to be closer to the 70%. So that means that we need to intervene, okay? That doesn't mean that there's nothing to do. It just means that we need to intervene. So then what are the options to preserve fertility? So we have this doom and gloom about chemotherapy, but then what are the options to offset that? So egg freezing, mature egg freezing is standard treatment. So you guys know it just as kind of egg freezing. It's been standard therapy since 2012. And the benefit is that no partner is needed. So a woman who is not yet partnered can freeze her eggs. It does require about 10 to 12 days of stimulation. And this is important for you to know to advocate for yourself. In the past, the teaching was that if a patient had to wait 4 to 6 weeks in order to freeze eggs. But now we have treatments that allow us to freeze eggs. If I see you today, they can start freezing your eggs within 48 hours by starting the medications, okay? So we don't need to wait for a menstrual cycle. So it's a shorter period of time. So for patients who have not yet undergone their treatment, I know you guys are all survivors, but you can certainly advocate for your peers. There's certainly time from diagnosis to cancer treatment to freeze eggs. It is a procedure, and it just involves placing a woman in a heel rest position, like in the stirrups, placing this probe in the vaginal canal. There is a needle attached to that goes into the ovaries. So when we stimulate, we're going to give you medications every day for 10 to 12 days. You're going to just kind of squeeze this area and inject every day. And the ovary is going to enlarge as the eggs start to grow. So then we would place this ultrasound probe, place a needle into each of these black circles that you see, and remove the eggs, place them into this test tube, and then take them to the lab and then freeze. And the eggs can be frozen indefinitely, can be frozen for decades. And there's no increased risk of birth defects from freezing eggs significantly over the regular population or the normal population. So that's important to know. We talked about stimulation occurring at any cycle, at any part of the cycle. And the other thing I want to emphasize is that there are treatments that we use to decrease the estrogen levels in your body. So when you have a breast cancer diagnosis, hormones are always on your mind, right? Which hormones? I can't have any hormones. Hormones are going to cause the cancer to grow. We want you to know that even though IVF or stimulating causes an increase in estrogen, there are treatments that we use to decrease those levels of estrogen. So it is safe to preserve your fertility by undergoing IVF during your cancer treatment. So before you receive chemotherapy, you are able to undergo IVF. Some patients who have large masses and need to undergo chemotherapy before surgery, they always worry, well, can I stimulate with the tumor in place? And there is research to say that that is possible. It depends on how fast growing the tumor is. But I want you to understand that the standard of care is to have you undergo IVF with treatments that minimize the overall estrogen that you produce, so it is not harmful to a woman with breast cancer to undergo IVF. The cost, $5,500 to $8,000. It's typically about $8,000. When you use LiveStrong and those organizations, you can get the cost reduced to around $5,500. And then meds are usually free if you go through that process. And the success rates are good, 35 to 50%. The normal success rate every time you try to have sex is about 25%, but that accumulates so that by 1 year it's 85% success rate. So with this, it's 35 to 50%. Embryo cryopreservation includes taking the eggs, as we discussed, and then partnering that with your partner's sperm. So taking the sperm and the egg, and then this is ICSI, where we actually put the sperm into the egg. The standard way is to just kind of put them in a petri dish and kind of let the best man win, right? Get to the egg and create an embryo. This is a way to make sure that there is fertilization that occurs. So that is what happens when you do embryo freezing. So 10 to 12 days of stimulation, retrieve the eggs, eggs, take your partner's sperm or donor sperm, create an embryo, and freeze the embryo. And the embryo also can be frozen indefinitely. Let me just go back one second. The downside of embryos, and this just depends on your situation. Embryos belong to both you and your partner. So you need to be sure that there is a good understanding of what is going to happen to those embryos should the relationship dissolve. Because courts have awarded embryos to both the male and the female. So if this is your only opportunity to have children, you need to be sure. So some patients, if they can have eggs and embryos freezing, that's what they do, and that would be a recommendation if you have enough. There are certain ways to freeze eggs that have just as good a success rate as freezing embryos, but you need to know what that success rate is in the center you're using. Vitrification is the term you want to hear. So are my eggs going to be vitrified, or are you going to slow freeze my eggs? So vitrification has a higher success rate than just slow freezing, okay? So you just want to kind of ask those questions. And LiveStrong probably has some resources that can hook you up with different IVF centers to help you. Okay? Okay. There are some investigational therapies, and we won't spend much time with this. The only one I want you to really look at is at the bottom. It says gonadotropin-releasing hormone agonist. If you've gone through treatment, then you are familiar with the term Zoladex or goserelin. That is a GnRH agonist, and studies have shown that when women receive this injection or this treatment during their cancer treatment and afterwards, it protects their fertility. So there have been many studies in the past that says, some said yes, that injection does protect your fertility, and some said no, it does not. But we see that in breast cancer patients who receive this, we do think that there is a preservation of fertility. So if you receive that, that is beneficial, but it is not a guarantee. So we always need to still monitor you to make sure that you have hormonal function afterwards. This is what you asked me about, pre-implantation genetic diagnosis. It's a way to identify if there's a single gene mutation associated with cancer risk, and there are many genes that can be tested. And so if you look here, so this is what it shows you. This is the blastocyst, this is the inner cell mass that's going to become the fetus, and this is the tissue that will become the placenta. So you see here, this is just taking those placenta cells and not affecting the fetus, where the fetus is going to form, okay? So I just wanted you to know that. And then when we test it, we look to see which one is unaffected, which one is affected, and then we transfer the unaffected embryo in, okay? Yes?
When do you recommend?
When do you recommend, sorry, when do you recommend doing genetic testing? Because I want to find out the gender, because I'm like, well, if I had to do this, I'm going to have a boy and a girl at one time.
Sure.
So I'd like to find out now, but my oncologist told me to wait 5 years to have these, my boy and my girl.
So that is sex selection. That is sex selection, which is different from PGD. There's pre-implantation genetic selection and genetic diagnosis. This is for actual mutations, and selection is for sex. And so you're saying that he's asking you to wait 5 years to freeze embryos?
No.
Okay.
So I have 5 embryos,
Uh-huh.
and I want to find out which of them
Are male or female.
You would do that at the time that you're ready to transfer. So you don't need to do them now. You need to do them at the time that you're ready to transfer.
If I wanted to find out now instead of waiting.
They
for
need
5
to thaw them
And
in
is
order
that-
to do that. You don't want to do that.
I don't
unless
wanna
you-
do that.
Until you're ready, correct.
So if I thaw, so they'll thaw them before putting them
Transfer.
in me. That's how they do it.
Yes, that's how they do it. That's right. I actually have a picture, and actually that is exactly how they do it. So you got it. So yes, so I would wait until you're ready. You're ready. So then what is the optimal time to conceive? So you've been diagnosed with cancer, you've undergone your treatment, you're in survivorship, and so when is it time to conceive? But before we conceive, we always have to talk about contraception. Like, contraception is super important because, as I said before, there are women who abort because they don't think they should conceive. And so the important thing is to contracept until you have all the information and you know when is the right time to conceive. So during chemotherapy, there are risks of birth defects and early pregnancy loss if the fetus is exposed to chemotherapy, and that's within 6 months of completing chemotherapy as well. So we recommend abstinence when the ANC is low. So when your ANC is low, that means your white blood cell count is low, your immune system, defense system is low. When you have intercourse, we have micro abrasions or cuts in the vaginal wall that you don't even notice, and bacteria goes through that wall and can get into your bloodstream. So you always want to be careful about when you have sex during your treatment. You all are survivors, but it's just important to note. And then we always recommend for contraception, non-estrogen containing, long-acting reversible contraceptives, because these are the most reliable. So how reliable are they? So down below, the withdrawal method, this like crossing your fingers, I hope I don't get pregnant, I hope I don't get pregnant. Like nobody except like high school people, use that. Don't do that. It's like, 24 out of 100 times you would get pregnant using that. Fertility awareness is great when your cycles are very regular. But remember, when chemotherapy is affecting your follicles, you can bleed irregularly, you don't really know when you're fertile. So that is not the time to use that technique. Diaphragm condoms should be used to minimize risk of sexually transmitted infections. So if you go higher up, the failure rate is 6 to 9 in 100 women will fail the pill, the patch, the ring, the shot. That's with perfect use. So with perfect use, there will still be some failures. So we also do not recommend that. And as you can see, all of those have estrogen except for the last one, Depo-Provera, so you wouldn't use that anyway, being a breast cancer survivor. So then really, really well are the ones where there's only 1 in 100 women will fail that treatment. And the Implanon is the most reliable contraceptive over anything. It's the one, or the Nexplanon, it goes in the arm, it's the rod. You would not use it because it's a hormone. There are several different IUDs. There's the Skyla and the Mirena. You would not use that because it's hormonal. Paragard is a copper IUD. That's the contraceptive of choice for your population because there are no hormones. And then sterilization is not something we would recommend until you were ready, you had completed your childbearing. So the copper IUD, also known as Paragard, as you can see, it's really small. It has that copper wire. It's good for 10 to 12 years. There's no hormonal side effect. It is the most effective method of emergency contraception. So that means that if you have an oopsie and you place a copper IUD within 5 days of that oopsie, then you will be contracepted. So it is the only birth control that we can use for emergency contraception as well. Okay. So this is what I wanted to describe. It takes about 6 months. So this is just to show you when you go from an immature follicle to an ovulatory follicle, that takes 6 months. And during that time, that egg is just growing like gangbusters. And anytime any cell that's growing can incorporate DNA damage, and it can cause birth defects. So 6 months after you receive chemotherapy, do not try to conceive. Part of that is the eggs just really aren't mature enough anyway. So the likelihood of conception is going to be low. And if you do conceive, the risk of birth defects are going to be high. Ovarian reserve testing is something I wanted to bring up because you may have heard this term AMH. So you're ready to conceive and you want to know, can I conceive? Can I have a baby? An AMH test is something you'll hear about. And I think it's important for you to understand what the levels mean because the numbers are low and a lot of patients get freaked out when they hear my level is 1, which actually is great. But you need to know that 1 to 3.5 is normal. A low level is 0.5 to 1, and very low is less than 0.5. So if your value is very low, that means that your reproductive window is shortened. You've lost some eggs because your eggs make this hormone, and that means you need to consider trying to conceive at that time or undergoing IVF to preserve your eggs so that you can conceive at the right time. Basically, we will do a baseline AMH to assess your fertility before cancer treatment, and then we'll check your AMH yearly afterwards to kind of follow it. So basically what we're trying to do is determine after your cancer treatment, when can you conceive? So we just check every year and your AMH should remain like this. When it starts to drop, that means you're losing your fertility, and that means we need to intervene. Okay, so that's why we would draw that. FSH is another hormone that you may hear about. It's produced in the brain. When our eggs aren't working well, it makes our brain push that FSH out. So the higher that level, the more that means that your ovaries aren't working well. So if that level starts to rise, then it triggers us to say we need to preserve your fertility or we need you to try to conceive now. So those are the 2 tests that you may hear about. Yes.
So I'm a 25-year-old triple negative breast cancer survivor, stage 2. I'm about a year out.
Congratulations.
Thank you. It's very exciting.
Yeah.
I have one daughter. and I don't have any eggs preserved. It really wasn't talked about to me.
Sure.
And I don't really want to do IVF. That's just not for me since I do have her. But I am 3 months out from capecitabine. And of course, I've been told I need to wait at least 6 months, but I hear different things on 2 years, 3 years, you know, all of that. But I did go ahead and have my FSH and estradiol tested, actually this week.
Okay.
He did not do an AMH, and I did ask why.
Because AMH has not yet been able to reliably predict pregnancy, the likelihood of a live birth. So there are women who have an AMH of 0.5 who go on to conceive just fine. And so because of that, some people don't feel that it's important to draw that. But if your AMH were 0.05, that's that gives us an idea that that's really on the lower end, and you just need to be cognizant that over time it decreases. So it can help you to know when to pull the trigger.
So I've actually received a recurrent loss diagnosis before I had cancer, before I was diagnosed with cancer.
Okay.
I met that criteria just a couple months before
Okay.
my diagnosis of cancer. So I should push for him to do it just so we know and at least have a baseline of this AMH, or?
It may be helpful to get that. What's possibly more helpful is to do an ultrasound to count how many eggs you actually have in your ovaries, called an antral follicle count.
Okay.
That's probably going to be more helpful, because if that number is like 10 or greater, you know that you're good. If
Okay.
that number is it's lower than that, like less than 6, then you know that you need to move forward. So probably better than the AMH would be to have an ultrasound to show. The great news is that you are 25, and so you probably do have good function. What was your FSH?
7.
7, okay. All right, so good. So you probably do have good function, but an ultrasound is going to be probably the biggest bang for your buck
Okay.
at this point.
Okay, yeah, I did Lupron through chemo.
Okay.
So
Okay, good.
that's what that was my only option. Yeah.
Sure.
Thank
So you're
you.
going to be probably on so triple negative, you receive dose-dense chemotherapy, right? So you receive a greater dose in a shorter period of time. That can have a little bit of an effect, but your age is really on your side.
Thank you.
You're welcome.
How does use of ovarian suppression as treatment for breast cancer affect your reproductive window? So if I'm on Lupron for 10 years and I'm not producing eggs during that time, does that kind of push it out because those eggs are saved, or will I just continue to decline as a normal person would decline with age?
Yeah, so even with the Lupron, there are some follicles that are going to undergo atresia, so that atretic loss is still going to continue. But the idea is that the Lupron is making your ovaries quiescent, meaning they're not dividing, so they're not incorporating that DNA damage, so you're not losing as many as women who are not on Lupron, but you are still losing some. So it doesn't, if you're on it at age 25 for 10 years, your ovaries are not always age 25, right? So they will continue to age, but not at the rate that they would if you had not been on that. That is the idea. Now, I will tell you, there's very conflicting data in patients with lymphoma and leukemia and sarcoma where there's just doesn't seem to be any benefit. So intellectually, we keep asking ourselves, well, why would it be any different in a patient with breast cancer than in other populations? Was it that the studies were just better? But it seems to have been borne out several times, so we do think there is some protection, but we don't want you to hang your hat on it, right? We want to make sure that you get assessed when you finish your treatment, okay? Okay, so once you have identified that you have follicles and you want to conceive, preconceptual counseling is really important. So again, if we want you to wait those 2 years, at least 6 months, but those 2 years to allow for time of recurrence. But then we need to make sure you're healthy. So it's not appropriate to conceive if your cardiac status is not where it needs to be. There are treatments that women receive that affect cardiac, pulmonary, renal, endocrine. All of those systems need to be assessed before you try to conceive. And so typically we'll have you see a high-risk specialist to make sure that these conditions are well managed. You could start with just your regular GYN and OB, and if you have none of these issues, you don't need to see a high-risk physician. But if you have concern or there's some sort of compromise, and you need to see that person before you conceive. They're not going to tell you you can't conceive. What they're going to do is help optimize your health so that you have a safe pregnancy. And then many times patients tell me, well, what can I do just to optimize my natural fertility? And so maintaining a healthy body mass index is the most important thing you can do. So your body mass index is how much you weigh for your height. And that should be between 19 through 24 is what the number should be. And anything above that decreases your fertility, and anything below that decreases your fertility. So if you are trying to optimize your health, trying to get your body mass index in the right window, because if it's not, then you don't ovulate consistently, and then it can be difficult to conceive. Exercise, same thing. You don't want to be underweight, and you certainly don't want to be overweight, because when you're underweight, your body, you need fat to ovulate. You just need some fat. So if you're underweight and you're extremely lean, you look great, your cardiac function is great, but your ovaries are typically not so happy. So you need to make sure that you're not over-exercising, because that can affect your fertility as well. And then lifestyle, so alcohol we think can affect fertility. We know that it can affect the pregnancy, so you want to minimize that. Once you conceive, no alcohol. So there's no longer any dose of any amount of alcohol that we think is safe during pregnancy. Not one glass, not half a glass. We recommend no alcohol. Marijuana, same thing, not safe, affects your fertility. You don't want to smoke marijuana. Smoking, same thing, affects your ability to conceive. And then caffeine, we think that less than 2 cups a day has no adverse effect, so you don't want to go over that. So those are some of the things you can do naturally. You want to be careful with supplements. There are a lot of supplements out there that help women's fertility, and they do work, but they're not for you, because they have components in them that are called phytoestrogens, and those have estrogen in them, and they metabolize your estrogen. So you want to be careful with that. Don't do supplements. Prenatal vitamins, yes, every woman should be on one of those. If they're thinking about conceiving, at least 3 months before you want to conceive, you need to be on prenatal vitamins. So that's the only thing I would recommend, and then everything else is diet and lifestyle. And then once you conceive, obviously prenatal care is super important. Again, conception 6 months after diagnosis is unlikely to compromise survival, but most clinicians advise women treated for early breast cancer wait 2 years from diagnosis before attempting conception to allow early recurrences to manifest. And then patients with regional spread advised to wait 3 years from diagnosis. And so you asked me about that from diagnosis. Treatment holidays, so patients on tamoxifen, aromatase inhibitors, HER2 new antagonists, all of those, the patients who have hormone receptor positive tumors want to know, do I have to wait 5 years before I can try to conceive? If you're 35, then waiting till you're 40 obviously is not a good plan, right? So we think there's a study out now called the POSITIVE study that we think is going to show that if you are on your tamoxifen or aromatase inhibitor for 2 years, you can come off and have a treatment holiday, meaning conceive, and then after that go back on your treatment to complete your 5 to 10 years. So that's what we think the studies are going to show us. Some of the studies so far have shown that it's safe to take a brief time to conceive. Now, what this means is that you can't wait a year of trying to conceive naturally. Like, we need to get going. So typically, if a woman is unable to conceive naturally within 3 to 6 months, we will recommend that we intervene. And that can be something like Clomid. Actually, we wouldn't use Clomid for you. Letrozole is a medication that we would use to help you conceive that is safe in breast cancer. Okay, so you can receive 1 or 2 letrozole tablets daily for 5 days. Yes?
So my doctor, I live rurally, so I don't have access to a lot of, great doctors that are doing the research.
Sure.
And he actually, obviously this is incorrect and everybody in this room knows that I can't do IVF because of the breast cancer.
Right.
So I'm triple negative, so mine wasn't impacted by hormones. So would Clomid be an option for me, or would I just to be on the safe side stick with the
Coleman
letrozole?
would be an option, but letrozole works just as well.
Okay,
Yeah.
perfect. I think I've heard it has fewer side effects.
It does.
Okay,
Yep.
so you agree with that and recommend it for that reason
Yes,
as well?
it has fewer
Okay.
side effects. Yeah, because the side effects are estrogen side effects. So hot flashes, moodiness. Some women would say like just craziness, right? And but the letrozole has less of that and it's more short-lived, and the fertility rates are the same, and actually less likelihood of twinning.
Okay, perfect. Thank you so much.
You're welcome. And we're happy, if you need a telehealth consult, if you want to reach out to me at OSU, I can do a consult from afar. I can send a note to your oncologist because they just don't know, right? And unfortunately, their not knowing impacts your future, right?
It was my OBGYN. No, I don't think we even have a reproductive endocrinologist.
Probably not. It's hard to come by.
So I would love that.
Yeah, absolutely. Be happy to.
If you have a background in endometriosis.
I do.
My doctor, he thinks I have it, but we didn't do surgery, and I see that that's the only way you can diagnose it.
Correct.
So
Sure,
Yeah.
sure. Again, the good news is you've had a child, but that doesn't, it doesn't mean that we don't need to be careful. But I think letrozole, if you're not interested in IVF, would be a great option for you, and we can walk your OB through how to use it. They should know how to use it, though.
should know.
Yeah.
But of course, I don't know anything.
Sure,
I need
yeah.
somebody to
Walk them through. Yeah, and we do that all the time.
Yeah.
Yeah, happy to do it, okay? Let's see here. Aditi talked a little bit about, adoption, donor oocytes, and I'm so thankful to know that LiveStrong actually helps with donor. I didn't know that they help with donor oocytes or gestational surrogate, but you can see it's expensive. And so I just put this up here because I think that it's really important that as physicians, we try to help you use your own gametes if possible, because none of this is inexpensive, right? And so using a donor oocyte or a donor egg is more expensive, or donor embryo is more expensive than trying to use your own. And so we really don't want women to lose the opportunity. So please advocate for your peers that they need to have these conversations so that they don't necessarily have to be faced with $100,000 for a surrogate or $35,000 for adoption. And then some adoption agencies are biased and don't always allow patients who've had a cancer diagnosis to adopt. I think we've gotten better about that, the stigma of that. And so, and then I think lastly, health and wellness and survivorship. I really just want you to know that it's not always just about fertility, right? Fertility is very important, but it's also about you having an overall feeling of well-being. Your bone density is important. You're going to be on all these treatments that are minimizing your estrogen and thus affecting your bones. So you need to pay attention to that. Vasomotor symptoms, hot flashes, vaginal dryness, pain with intercourse. All of those things need to be addressed so that you can be intimate if you choose to be intimate. And even if you're not intimate, you shouldn't notice your vagina. If your vagina is dry and itchy every day, that's uncomfortable. So even if you're not having sex, that should be addressed so that you feel well throughout the day. And there are treatments that we can use for patients with breast cancer. So typically we use estrogen to treat these symptoms, but you can't have estrogen. So we have other treatments, and you need to know that there are other treatments that are not hormonally based that we can use to help you. We do screening for sexual dysfunction on all of our patients because we want to make sure that you are not just having sex because you feel like it's your duty, or you feel as though I want him to stay, and just whatever. We want you to have sex because you enjoy it. We want you to enjoy it. And so there are really good sexual therapists who can help you as a couple, help you individually, so that you enjoy that part of your femininity. And again, an overall sense of well-being, which goes to just making sure we address all of these issues for you. So advocate for yourself and say, hey, I want to speak to someone about this, or I have this concern, because unfortunately not every doctor is going to ask. So that is the end of my talk. Do you have any questions for me aside from the ones that you've asked? And I want to say again, I am available to do telehealth consults. Many times I just talk to people on the phone. It doesn't need to be like insurance changing hands or any of that. I talk to providers all the time about what they should be doing for you. So happy to share that information. I should have had it up here so that you can reach out by email. You can feel free to reach out by email, and then we can kind of correspond with you. Okay.